Welcome to the deep dive. Today we're tackling a really critical topic: acute mesenteric ischemia.
Mm-hmm.
Think of this as your high-yield briefing, aimed squarely at helping you nail this for exams like the MSRA.
Absolutely. We've pulled together all the key stuff from the revision notes, definition, causes, diagnosis, the works.
Yeah, and we want to make it stick. It can seem daunting, but we're here to break it down.
Exactly. We'll go through it step by step, what it is, why it's so serious, how to spot it, the tests, the treatment, giving you those memory hooks too. Ready?
Let's do it. So, first things first. Acute mesenteric ischemia, or AMI. In simple terms, what are we actually talking about here?
Okay, so fundamentally, AMI is when the blood flow to your intestines gets suddenly cut off or severely reduced.
Right.
It's usually down to a problem with the mesenteric vessels, the arteries or veins supplying the gut. Often it's a blood clot, either forming right there, a thrombus, or one that's traveled, an embolus, or just a blocked artery.
And that sudden cutoff, that's the dangerous part. Why is it such a big deal?
Oh, absolutely, because when the gut doesn't get blood, it doesn't get oxygen, and things go downhill fast. You get tissue damage, then tissue death, necrosis, we call it.
Necrosis, okay.
And that can lead to all sorts of really severe, life-threatening problems if you don't jump on it quickly. Time is absolutely critical in AMI.
Got it. So, sudden blockage, lack of blood, serious consequences. Let's unpack the causes then. What are the main ways this blockage happens?
Well, we can sort of group them into four main buckets, and knowing roughly how common each one is can be useful. Number one, responsible for maybe half the cases is arterial embolism.
Arterial embolism, so that's the traveling clot.
Exactly. A clot breaks off from somewhere else, often the heart travels through the bloodstream, and gets stuck in one of the mesenteric arteries. Bam! Blockage.
And how can we remember the risk factors for that specific cause? Any tricks?
Yeah, you can think of a heart escaping, like breaking free and blocking a pipe.
A heart escaping. I like it.
It helps remember the cardiac stuff. So atrial fibrillation, AF, that's a big one for forming clots. Then maybe clots forming on the heart wall after a heart attack, a mural thrombus. Prosthetic heart valves can be a source too. And things like aortic aneurysms, bulging vessels where clots can form and break off.
That's helpful, the escaping heart. Okay, what's next on the list of causes?
Next up, accounting for maybe 25% is arterial thrombosis.
Thrombosis. So this time the clot forms in the mesenteric artery itself.
Exactly. It forms right there, usually because the artery is already narrowed or diseased.
And what's usually behind that narrowing?
Think hard arteries getting blocked.
Hard arteries, atherosclerosis.
Precisely. Atherosclerosis, hardening of the arteries, that's the main culprit here. The artery is already narrowed by plaque, and then a clot forms on top, blocking it off.
Okay, so embolism, escaping heart clot. Thrombosis, a local clot in hard arteries. What's number three?
Number three is a bit different. It's called non-occlusive mesenteric ischemia, or NOMI. That's about 20% of cases.
Non-occlusive, so no blockage.
Right. The pipes are open, technically, but the blood flow through them is drastically reduced. It's usually because of problem elsewhere in the body, causing really low blood pressure or poor circulation overall.
Like the whole system's pressure is down? What kind of situations lead to that?
Okay, for this one, picture a fainting heart.
A fainting heart.
Yeah, like it's just not pumping effectively. So think low flow states. Maybe after major heart surgery, severe heart failure, kidney failure, or states of shock like hypovolemic shock, low blood volume, or cardiogenic shock where the heart pump itself fails. The gut just doesn't get enough blood perfusion.
That makes sense. The supply's okay, but the delivery system's failing. Okay, and the last category.
The last one, and the least common, less than 10%, is mesenteric venous thrombosis.
Venous. So this is a clot in the veins draining the bowel, not the arteries supplying it.
Exactly. Clot forms in the mesenteric veins, causing congestion and preventing proper blood flow.
And are the risk factors different here? Who gets this?
Yeah, they tend to be a bit different. Think young blood becoming thick to sick.
Young, thick blood.
It often affects younger patients compared to the arterial types, and it's usually linked to things like hypercoagulable states where your blood clots too easily, also malignancy, inflammatory conditions nearby like pancreatitis or diverticulitis, or sometimes trauma.
Okay, great mnemonics there. Escaping heart for embolism, hard arteries for thrombosis, fainting heart for non-occlusive, and young, thick blood for venous. That really helps. So, pulling back a bit, what are the general overarching risk factors we should look out for? Things that make someone more prone to AI overall.
Well, a lot of them tie back to those causes, naturally. But yeah, key general risks, definitely advanced age over 50, especially over 60, any kind of cardiovascular disease, particularly atherosclerosis, that's a recurring theme.
Right.
Atrial fibrillation, again, a major cardiac risk. Having a known hypercoagulable state or history of clots, like a DVT or PE. Having had major abdominal surgery in the past. Things like an aortic dissection or aneurysm. And then, like we touched on with NOMI, conditions causing decreased cardiac output, a recent heart attack, chronic heart failure. It all points towards compromised circulation.
Yeah, it really hammers home that link between heart health, vascular health, and the gut. Okay, let's get down to the nitty-gritty. The pathophysiology. What's actually happening inside the bowel when the blood supply is cut off?
So the core issue is that sudden drop in blood flow. Almost immediately, the bowel tissue isn't getting enough oxygen. That's hypoxia. And
Right.
without oxygen and nutrients, the cells start to get damaged. That's the ischemia.
And this damage happens quickly.
Very quickly. The lining of the intestine is particularly vulnerable. If that lack of blood flow goes on for, more than a few hours without being fixed, the damage becomes irreversible. The tissue starts to die off. That's the necrosis we mentioned earlier.
And I guess how bad it gets depends on a few things.
Exactly. Two main things really determine the severity. One is the extent of the blockage, how much of the blood supply is affected. Is it a main vessel or a smaller branch? The second is the duration. How long has that blood flow been critically low or absent? The longer it goes on, the more bowel dies.
Right, makes sense.
Yeah.
Now, a patient comes in with bad abdominal pain that could be loads of things.
Yeah.
What else needs to be on our differential diagnosis list when we're thinking about AMI? This sounds like classic exam territory.
Oh, absolutely critical for exams and real life. Acute abdominal pain is so nonspecific, so your differential needs to be broad. You've got to think about things like a leaking or ruptured abdominal aortic aneurysm. That's another vascular emergency.
Okay.
Then the common surgical stuff. Appendicitis, cholecystitis, or other biliary problems, diverticulitis. You need to differentiate acute from chronic mesenteric ischemia, too. The chronic form usually has pain after eating, sort of develops over time.
Right, different pattern.
Definitely. Also, consider a bowel obstruction from another cause, maybe adhesions. A perforated viscus, like a hole in the stomach or bowel. In women, ectopic pregnancy is crucial, even severe pain from H. pylori ulcers. And don't forget causes outside the abdomen that can present with abdominal pain, like a lower lobe pneumonia or even a myocardial infarction.
Wow. Even an MI can present like that.
Yeah, sometimes the TANE refers. Also think about pancreatitis, though. Amylase can be up in AMI, too, remember. Less common things like pneumothorax or rare metabolic causes like acute intermittent porphyria. And in guys with lower abdominal or groin pain, always, always rule out testicular torsion.
That is a seriously broad list. Really shows why AMI can be tricky to diagnose initially. Okay, shifting gears slightly, how common is AMI? Who usually gets it?
Epidemiology-wise, in the UK, it's estimated at roughly 1 in 100,000 people per year. So not super common, but definitely significant because it's so serious.
And age-wise?
It definitely skews older, much more common over 50, and the risk really climbs over 60. It accounts for a small percentage of all hospital admissions, maybe around 0.1, 0.2%, but carries a disproportionately high mortality rate.
Okay, so relatively rare, older population, but deadly. Now, the clinical picture. How does a patient with AMI actually present?
Right.
What signs and symptoms should make us think, hang on, could this be AMI?
Right, the presentation. It can vary, which is part of the challenge, but there's a classic feature you need to know. The absolute hallmark is severe abdominal pain. But, and this is the key bit, especially early on, the pain is often way out of proportion to the physical findings.
Pain out of proportion, that's the classic phrase, isn't it?
Exactly. You examine the patient, their abdomen might feel relatively soft, maybe only mildly tender, but they are telling you they're in agony, maybe writhing around. That mismatch is a massive red flag for AMI.
Okay. What else?
The pain onset is usually sudden. Nausea and vomiting are really common too. Maybe 75% of patients have that. And as things progress, you might see signs the patient is becoming unwell, systemically fast heart rate, low blood pressure, tachycardia, and hypotension.
Does the pain itself change?
Yeah, it can. Initially, it might be a bit vague, maybe crampy or poorly localized, but it usually becomes more constant and just relentlessly severe. Later on, if the bowel starts to die and get inflamed, you might then see the more classic signs of peritonitis, like rebound tenderness, guarding. But that often means things are quite advanced. Sometimes you might feel a mass. And always look for clues to the cause, like an irregular pulse suggesting AF.
So that early stage, severe pain but a relatively benign-looking belly, that's the crucial window. Okay, suspicion is high. What tests do we order? What investigations confirm it?
All right, investigations. You need bloods and you need imaging urgently. For blood tests, an arterial blood gas and ABG is vital. You're looking for a raised lactate and metabolic acidosis. That screens tissue under oxygenation, ischemia.
Raised lactate, key finding.
Definitely. Full blood count, FBC, often shows a raised white cell count, WCC, from the inflammation. Hemoglobin might actually be high due to hemoconcentration, losing fluid into the bowel wall. UNEs, urea, and electrolytes essential to check kidney function, especially before contrast CT. Look at urea, creatinine, EGFR.
Yeah.
LFTs, liver function tests, sometimes raised AST and ALT can suggest liver hypoperfusion, which isn't a good sign. A clotting screen is important, especially if they're on anticoagulants. Amylase, check it to help rule out pancreatitis, but remember it can be raised in AMI as well. And group and screen, GNS, maybe cross-match blood because these patients might need surgery and transfusion.
That's a good set of initial bloods,
Okay.
but the real answer comes from imaging, right? What's the definitive test?
Absolutely. The gold standard, the test you need is a CT angiogram of the abdomen and pelvis.
CT angiogram,
Yeah.
CTF.
Yep. That involves injecting intravenous contrast dye while doing the CT scan, specifically timing it to light up the arteries, or sometimes the veins. It lets you see the mesenteric vessels directly. You can spot blockages, narrowings, clots, filling defects. It's the best way to confirm the diagnosis and see what's going on.
What about other imaging, like a plain X-ray?
A plain abdominal X-ray, AXR, is often done, but it's usually not that helpful early on. It might show some nonspecific signs later, like dilated bowel loops, maybe thickened bowel wall. If you suspect perforation, an erect chest X-ray looking for free air under the diaphragm is important.
Right.
Ultrasound or MRI aren't typically first line for acute AMI. An ECG is essential, though. Look for AF or signs of an MI as a potential cause. An echo might be done later to look for cardiac sources of emboli. And sometimes during surgery, they might use fluorescein dye to check bowel viability.
So really, it's all about getting that CTA quickly if you suspect AMI. Bloods like lactate and WCC support the suspicion, but CTA gives the diagnosis.
Exactly. Early diagnosis with CTA is crucial for improving outcomes. You might see signs on plain CT too, like bowel wall thickening or even gas in the bowel wall, pneumatosis intestinalis, which is a very bad sign suggesting infarction. But the angiography part with the contrast, that shows you the vessels. That's key.
Okay, diagnosis made. Now, management. This sounds like an emergency. What do we do?
It is a massive emergency. The goals are simple: get blood flow back to the gut and deal with the underlying cause. First steps are resuscitation, ABCs, high flow oxygen, intravenous fluids, often lots of them, to support blood pressure,
Okay, fluids, oxygen.
a nasogastric tube, an NG tube to decompress the stomach and bowel. Broad spectrum IV antibiotics are vital because bacteria can leak from the damaged gut wall,
Antibiotics.
and anticoagulation. Usually intravenous unfractionated heparin is started straight away, unless there's a major reason not to stop clots getting worse and maybe help dissolve existing ones.
And surgery. Is that usually needed?
Very often, yes. If the patient has signs of peritonitis, that rigid abdomen, rebound tenderness suggesting dead bowel, they need an urgent operation, a laparotomy.
Well, laparotomy. Okay.
The surgeons go in, they assess the bowel. Their aims are: 1, try to restore blood flow if possible, maybe remove a clot, embolectomy, or do a bypass graft. 2, cut out any bowel that's clearly dead or non-viable. And 3, save as much healthy bowel as they can.
Is there anything less invasive?
Sometimes, particularly if it's caught early and it's maybe a partial blockage, endovascular options might be considered. Things like using clot-busting drugs delivered via catheter right to the clot, or angioplasty and stenting to open up a narrowed artery. But often, open surgery is needed, especially if there's suspicion of dead bowel.
And after the immediate crisis, what about long-term?
Long-term, it really depends on the cause, but many patients will need lifelong anticoagulation, maybe with warfarin or a DOAC, or antiplatelet drugs like aspirin to prevent it happening again. And of course, managing all those underlying risk factors, AF, atherosclerosis, heart failure, etc.
Just to hammer this home for exam prep, AMI is up there in terms of surgical emergencies, isn't it?
Absolutely. Top-tier emergency. Delay kills. Complications like septic peritonitis, multi-organ failure can happen fast. So it's fluids, oxygen, antibiotics, heparin, and often a very quick trip to the operating theater to remove dead bowel. The mortality rate is frighteningly high. And even survivors can have major problems.
Yeah, let's talk about that, the prognosis. What factors influence how well someone does?
Well, several things really stack up. How long the bowel was ischemic before treatment started, that duration is critical. How much of the bowel was affected, the extent, whether complications like perforation or peritonitis had already set in. And tied to the first point, how quickly the diagnosis was made and treatment initiated. Speed is everything.
And the outcomes, statistically.
They're pretty grim, unfortunately. If it's missed or treatment is delayed, mortality can be as high as 90%. Even with prompt treatment, the death rate is still often quoted in the range of 50 to 90%. It's one of the most lethal acute abdominal conditions.
That's sobering.
Yeah.
And for those who do survive, what challenges might they face?
Survival often comes at a cost, especially if a lot of bowel had to be removed. The big issue is short gut syndrome.
Short gut syndrome.
Yeah, if you don't have enough small intestine left, you can't absorb nutrients properly. This leads to diarrhea, malnutrition, weight loss, vitamin deficiencies. It can significantly impact quality of life, and some patients might need long-term intravenous feeding, known as parenteral nutrition.
Right. A really significant long-term consequence. Okay, finally, let's just clearly list the main complications that can arise directly from AMI.
Okay, the big complications. First, bowel infarction itself, the death of the bowel tissue. That leads to peritonitis, infection, and inflammation inside the abdominal cavity as bacteria leak out, which can then lead to sepsis, a whole body infection.
Sepsis, okay.
The dead bowel wall can also perforate, literally burst open, spilling bowel contents everywhere. And all of this stress and infection can overwhelm the body, leading to multiple organ failure. These are the things that really drive the high mortality rate if they're not managed aggressively.
Okay. So wrapping this up, the absolute key message for acute mesenteric ischemia is, think about it, diagnose it fast, treat it fast.
Exactly.
That severe pain out of proportion to the findings is your biggest clue early on. Get that CT angiogram done urgently. Remember the high mortality, the need for resuscitation, antibiotics, anticoagulation, and often emergency surgery.
Yeah, and understand the different causes, embolism, thrombosis, non-occlusive, venous, and their risk factors. Those mnemonics might help you recall them under pressure. Heart escaping, heart arteries, fainting heart, young thick blood.
Absolutely. For anyone listening and prepping for the MSRA, really internalize this. Know the presentation, the key investigation, the emergency management. Consider how they might test this. Maybe a vignette about an elderly patient with AF and sudden severe abdominal pain.
Definitely. Knowing this topic well is crucial, not just for the exam, but for recognizing this killer condition in practice.
And don't forget, for more structured revision and practice questions, check out passthemssra.com and freemsra.com. They're fantastic resources. Keep pushing with your revision. You're doing great work.
Yeah, keep at it. You can definitely master this.